Welcome everyone to the opening session of our conference, and it is entitled New Advances in Colorectal Cancer Treatment. For this session, we have assembled an incredible patient, group of medical professionals and researchers, all to share with you the new advances in treatments for colorectal cancer. I'm going to do an introduction of all of the panelists who will be speaking today, and then we're going to get right into a conversation. First and foremost, I would like to introduce to you Dan Wadsworth, who was diagnosed with stage 4 colon cancer at the age of 40. He underwent numerous surgeries, chemo, radiation, and ablation treatments over the past 3 years. He is currently on a treatment break and continues to be closely monitored. Dr. Jennifer Spratlin is an associate professor in the Department of Oncology at the University of Alberta and a medical oncologist at the Cross Cancer Institute with Alberta Services. Dr. Spratlin is also the fellowship director at the CCI and a leader in physician wellness. Dr. Brandon Sheffield is a pathologist with the William Osler Health System in Brampton, Ontario. He currently serves as the Medical Director of Advanced Diagnostics and the Physician Lead of Research. Dr. Sheffield's main focus has been on the delivery of biomarker results to support personalized cancer treatment, with a particular emphasis on making these technologies available to community cancer patients. We'll be hearing more about that as part of the panel. Dr. Scott Barry is a medical oncologist, professor and head of Queen's University Department of Oncology. He is the medical director at the Cancer Centre of Southwestern Ontario at the Kingston Health Sciences Centre. Dr. Barry is an active participant in clinical research in gastrointestinal cancer and is a principal investigator for Canadian Cancer Trials Group Rectal Cancer Trial CO31. Dr. Barry loves teaching, and because of this has won several teaching awards. Dr. Vuong is the director of the Siegel Cancer Center's Radiation Oncology Department at the Jewish General Hospital in Montreal. She is currently a professor at McGill University Department of Oncology and holds the position of co-chair, McGill Radiation Oncology at the same educational facility. Dr. Vuong is internationally recognized, particularly for her expertise in the treatment and research of rectal cancer. Dr. Carole Richard is an experienced colorectal surgeon practicing at the University Hospital of Montreal, where she is the head of the Digestive Disease Department and leads the colorectal oncology team. Her main clinical focus is rectal cancer and complex IBD. Dr. Richard is also an associate professor at the University of Montreal, Department of Surgery, as well as a translational researcher. Dan, may we start with you, please? Can you share your story with us?
As mentioned, I was diagnosed in 2019, December 2019, at the age of 40. No real symptoms to speak of. I think I'd been in the hospital 6 times in my life, once when I was born and 5 times for my kids each time. So fairly healthy guy, active, things like that, nothing that stood out. Went in for some weird abdominal cramping discomfort, and I was actually not officially diagnosed, but they saw the cancer in the DER with the CT scan. So subsequent to that, started chemo right away, basically January 3rd, I think it was, January 4th, at our VH in Barrie. I did 6 months of chemo there, full Fox, with Avastin added in a little bit, about halfway through. Surgery was, I'm sure some of the doctors will speak to, was discussed at a tumor board. It was unsure at the time, had a really good response to chemo, thankfully. So surgery did come around for my liver disease and planned for my colon as well. The liver operation took place August of 2020. which was successful, thankfully. Clean margins, negative margins, I think they're called, which was a good thing. My colon tumor, as with myself, it's never straightforward. The surgeon wasn't able to find my colon tumor. She was a bit perplexed, so I did a follow-up colonoscopy. I believe that was October of that year. And she found that the colon tumor, although originally thought it was right-sided, it was actually left-sided colon tumor. I believe one of the doctors will speak about that as well, so that's interesting.
Yes.
So left-sided, but they found, thank goodness, that I actually had what's called the complete response in that primary tumor, and it was essentially gone. Scar tissue was all that remained. The doctor
So
did.
I'm the surgeon on board. I was wondering, did you have a colonoscopy at the beginning?
Not at the beginning, no. That came before treatments. I'm sorry, I did. Before treatment started, not in the ER. I had blood work, ultrasound, CT in the ER, and then I had a colonoscopy. The first one with 3 days, I think it was.
I mean, the pathologist and the onco people will be in accordance that usually that one of the first things that we do is the colonoscopy, and what the oncologists want is the biopsy. And often as surgeons, we say, we used to say, we don't say that anymore, but, this is a cancer. It's clear we don't really need the biopsy, but nowadays we do. So it's quite unusual that you had a colonoscopy and they told you that it was a right colon and they biopsied the right colon. And finally, after treatment, they told you that it was a sigmoid cancer?
Correct. And I'm not sure of the specifics, how the mix-up happened, but yes, essentially the biopsy did take place, which confirmed some, I was MSS or I'm MSS.
Right.
I don't have any real mutations except for one small percentage of a KRAS mutation. So
just, for basic knowledge, usually we start with the colonoscopy because we want to localize the disease in the colon, whether it's metastases or not. And usually we're quite right at determining the location of the tumor. And often even nowadays, what we'll do is we'll put India ink where the tumor is, because we know now with the fabulous chemo treatments that it's not unusual to have a major shrinkage where if we go on to surgery, we're not going to be able to see the tumor. So your case is quite unusual. First, that it was not a good location, and second, that they hadn't marked it with ink to show where the location was. That's just the comment I wanted to make because this is quite unusual.
Absolutely, and I think they did too. Is that called a tattoo? Is that when they tattoo it?
Exactly.
Okay, so they did in the original colonoscopy. The doctor who did the follow-up colonoscopy said that he saw the actual original tattoo in the left side sigmoid where the scar tissue was. So he said he was relieved to find that tattoo there because it wasn't another primary tumor. But yeah, he was confused as to how that happened too. It was a different doctor that did the follow-up. So, but thankfully it came with somewhat of good news in the fact that it did have a complete response. The one thing for patients that I can say quickly about the chemo, I was really don't think anyone looks forward to the chemo, obviously, but looking back, it was obviously such a huge part of why I had surgery, and even further to that, having my primary effectively disappear from the chemo was well worth it. After that, the colonoscopy, which was October 2020, I did have some small spots, or I do have small spots in my lungs, that we decided to do a watch and wait approach for those because they were very, very small. They were unsure whether they related or not to the cancer. So I actually had 9 months off chemo, and just very tiny minimal growth, but it was enough growth that my oncologist suggested that it would be a good idea to go back on chemo, make sure those are under control, obviously, and do an assessment from there. So I did 6 months of more chemo between April 2021 and December 2021. And throw in an ablation, as Anne-Marie mentioned, in March of 2021 for a spot that was missed in my liver surgery. I believe it was there in imaging, but just missed somehow. When they referenced back to the previous MRI, they did actually find it, so they knew it wasn't a new growth or recurrence or anything. So I've been now off chemo since December 2021, going on 6 months, and I'm effectively stable. Being monitored very closely by my team, obviously. CT scans every 2-ish months, work regularly, and we take it from there.
Yeah, great. Dan, thank you so much for sharing your story. And just as you were telling it, you've hit on a couple of the let's call the advances we do want to talk about as part of this panel. Things like wait and see, things like left side, right side, which we're going to get into a little bit more. And Dr. Richards, you, I think, already have tabled the value of a multidisciplinary approach just with your comments. So I'd first like to bridge into Dr. Spratlin, who really is going to share with us a little bit about immunotherapy and specifically some of the advances that are tying into molecular profiling.
Hi, I'm very happy to be here to help with this discussion. And I think I just want to point out that Dan's story does really speak to the fact that most patients come to us with very nuanced stories and their own pathway to medical care. So I think that's a very important thing for us to recognize and keep in mind when we're dealing with patients as our treatments become a little bit more personalized with our ability to use molecular profiling to determine some of these options. I usually start off talking to my patients and telling them that we have really, in the advanced setting, 3 different groups of treatments. True chemotherapies that go around the body and kill cancer cells and normal cells too, which is where the side effects come from. We also have biologics that are only useful in certain cases where there is either a mutation or no mutation in a particular pathway that will be discussed later on. And then we're also now having the ability to use immuno-oncology agents in one specific type of colorectal cancer. Dan mentioned that his tumor was MSS. That means microsatellite stable. He would not be a candidate for this new treatment that is available for advanced metastatic colorectal cancers who have not had treatment yet. But we do have a treatment called pembrolizumab that is an immuno-oncology agent that can be used in patients who have MSI high or microsatellite unstable disease now. There's varying degrees of how many patients that might be available for in the colorectal cancer world. The range of how many patients might have MSI high disease is probably somewhere between 5 and 12%. And we know that in a study that showed, the study that looked at patients who have stage 4 spread metastatic colorectal cancer that have not yet been treated with any treatment upfront, that are still doing well and that we can see spots of cancer in them. If we randomize them between standard chemotherapy, which would be the traditional treatment, versus this immuno-oncology drug called pembrolizumab, they end up often doing much better with just the immuno-oncology agent upfront. So that's a very exciting new find, and the most recent update on that was published in April of this past year. We in Canada have had access to it through special access programs for a little while. In my province in Alberta, we now have access to it under public health funding, which is fantastic. But again, I think it's just really important to point out that it is a small minority of patients who would be candidates for this.
Well, these patients are often what we call Lynch syndrome. And in our institution, we've been testing for the MSI for the last about 15 years. And as you say, we have about 8%. So it is a low percentage of patients, but I think it's necessary for them to be identified because it really is a change of attitude in terms of treatment.
I think it's a big change of attitude and perspective too. A lot of the time, chemotherapy can cause significant side effects. Immuno-oncology agents have their own version of side effects, and some of them can be not the best side effects, but they're very different than traditional chemotherapy side effects. And often people who are exposed to those drugs versus traditional chemotherapy do have less side effects. So that's something to consider as well.
Mm-hmm. Yeah, I think that's a really important point, Dr. Spratlin, because I think that one of the amazing things about that new immuno-oncology agent was not only that it helped people live longer, but it actually helped people have a better quality of life and help them live better. So I think that has not always been the case. Some of the drugs I'll be talking about later slow down the decline in quality of life, but this actually people's quality of life, which I think is really important to patients. Dan can comment, but I think that's something we always hope to offer our patients, is something that can not only hopefully cure, but if not cure, prolong their lives and improve their quality of life.
Right. Dr. Sheffield, I'm going to ask you to give us a couple words on molecular profiling and some of the advances that are happening in that space.
Oh, absolutely. So thanks everyone for having me on, and thanks Dan for sharing your story. I'm a pathologist or a laboratory specialist, and I think many of the patients on today will have met radiation oncologists, oncologists, and surgeons, but very few patients have ever met their pathologist, and there's really a lot of mystery about what we might do behind the scenes. And just hearing Dan's story, traditionally, we're the ones responsible for making that diagnosis. So when a biopsy is taken at a colonoscopy, we would look at it on a microscope like the one behind me, and we would say whether or not a polyp is malignant or pre-malignant or benign, and that would help direct patients to the most appropriate next therapy. Further to that, when patients undergo surgery, like resection of a liver metastasis or have part or their whole colon removed, we would then again confirm the diagnosis. We would look at the margins to say whether the cancer was removed in its entirety or if there were little spots left behind. Or in a case like Dan's, we would evaluate the response to chemotherapy and tell the oncologists and the surgeons whether or not the patient had a favorable response if there was any disease left behind. And that's really been the traditional role of the pathologist. And we sometimes call ourselves anatomic pathologists or surgical pathologists or histopathologists. But in recent years, we've had kind of a new job description that's really hit us in the laboratory, and that's molecular pathology. So what we do there is we take the little samples of tumor that are obtained in colonoscopy or by a surgeon during a surgery, and we'll do some additional techniques like sequencing the DNA or looking at proteins or even RNA. And those techniques allow us to see much more deeply and more clearly than we could see even with the most powerful microscope. And by communicating some of these findings to our colleagues in oncology, things like microsatellite stable versus microsatellite high or unstable, we can direct which treatments would be best for which patients based on things we find in their tumor itself. And I think that this is a really exciting paradigm shift in cancer care because it takes away a lot of the guesswork that oncologists have to do. And so we can tell them up front that a tumor is, say, microsatellite unstable and will be responsive to a drug like pembrolizumab. Or we can say whether a patient has a mutation like a KRAS mutation that Dan mentioned, which would make them resistant to drugs like EGFR inhibitors and allow oncologists to use drugs like Avastin. So really, in a nutshell, that is what we're doing in molecular pathology and also in the traditional pathology that happens inside of the laboratory.
Mm-hmm.
If for the oncologists who are part of this panel, how many of you have had experiences with molecular profiling? And if you could share those experiences, that would be great.
It's a pretty routine part. I mean, we work very closely with not only our surgical and radiation oncologists, but also pathologists. And it's pretty routine now to have at least some basic molecular profiling done for patients, including, as Dr. Sheffield said, their MSI status, RAS, which I'll be talking about a little bit later, another protein called RAF. And there are some other ones as well. But I think that, when I started treating colon cancer 25 years ago, seems like a long time ago, first of all, we didn't have a lot of options. We had one chemotherapy drug, didn't do very well, only had about an average survival of a year or slightly less. But we treated all colon cancers the same. And it's become clear now that really there are different types of colon cancer marked by the different biologic characteristics. Dr. Sheffield's test shows up. And it's really important for us to know the type of colon cancer somebody like Dan has to make sure that we're offering the treatments that are available. So we use it routinely now in the clinic.
Yeah, and I would just add that I think as our knowledge about these mutations and changes have increased, our treatment options have increased, and the survival and length of time that patients are living has also increased. So it shouldn't be lost that those things have gone hand in hand. The more we learn about the different types of colorectal cancer, the more we'll be able to talk to our patients about which ones they have and what they might be best suited to have for their treatment. And often that does result in them living longer.
Mm-hmm. And also there's another impact is that when patients are tested for these different characteristics, some of them will show that there is a family inheritance. And that makes a great deal of change in terms of recommendation of follow-up for the siblings or the brothers and sisters of that patient who has been identified with certain characteristic. And clinically, it makes a big difference, and it's important that knowledge is used for patient recommendation of follow-up.
I find
pardon me, go ahead.
Well, I was just going to say that I find for us in the laboratory, being a little bit removed, it's very important to keep in close communication with our colleagues in oncology and in surgery. As you heard so far, that a lot of these updates happen in real time. Like, so we're hearing about new drugs that are approved this year and data that's coming out in the year 2022. And so we want to make sure that the laboratory that's serving our clinicians and our patients is really kept up to date. So even though we've been doing some degree of molecular testing for many years, the exact nature and scope of that testing is under constant evolution. So while we started off doing tests like MSI for Lynch syndrome and hereditary purposes, we've now transitioned that to be a biomarker for immunotherapy as well. And while we used to test for just KRAS and BRAF, those are two genes involved in colon cancer, we could test for single gene tests. We now have additional markers, things like HER2, NTRK, and additional gene targets that have now led us to use a technique called comprehensive profiling, where we simultaneously sequence over 50 genes at a time for all our new colon cancer patients. So the process is very much in evolution, and it changes at least a couple times a year in recent years.
Okay. Dan, I was curious to understand whether or not you're aware that some of these molecular tests, molecular profiles were being used in your care to define and guide your treatment. I really like the point that the information that you get from that has benefit to your family. Were you exposed to any of that?
Yeah. So I didn't understand it at that time as well as I do now, obviously, but I do remember seeing my oncologist going over pathology reports with us, with my talking about different tests that the fact that it was hereditary cancer. They were able to rule that through the pathology and the gene testing that was done. So yeah, definitely it was there.
Mm-hmm. Mm-hmm. And was your family engaged in the conversation?
My wife was very much so. Yeah.
Very interesting. Okay, great. Dr. Barry, can I turn it over to you a little bit and to carry this conversation a little bit further?
Yeah, so thanks. And again, thanks for having me here. This is a great discussion. And thanks again to Dan for sharing his story. I think I'd like to talk, we've been throwing some terms around. And I think Dr. Spratlin's classification of the types of therapies we have, additional chemotherapies. And I said when I first started treating colon cancer in the late 1990s, I only had one. With time, we've actually had now 3 activities that can be used. But there have been major advances in the biologic treatments. And this really has come because of a much better understanding of the biology of cancer and colon cancer. And I think one of the biggest advances was a couple of drugs called cetuximab and panitumumab. These are drugs that are monoclonal antibodies. They are antibodies that take over something called the epidermal growth factor. And the epidermal growth factor is like a key that goes into a lock and turns on biologic pathways in the cell that make them grow faster. So these monoclonal antibodies can neutralize, in this case, the receptor. You can actually get turning off of those biologic pathways that produce cancer growth and slow down cancer growth. And it became clear that these drugs were effective, and these drugs were actually the first major trial that showed that these drugs were effective was done in Canada by the Canadian Cancer Trials Group. And I'm sure Dr. Spratlin was involved and I was involved in this really advanced care. One of the first biologic therapies that were available in colon cancer. And these were for people who had already been through many types of treatment and who didn't have a lot of treatment options available. We now know that they actually work with chemotherapy as an initial treatment for colon cancer and are very effective. And in the large trials we do comparing them to other standard treatments have shown they really help people live longer. A couple of things that have come up in our understanding is that we found out along the way that one of the biomarkers that Dr. Sheffield was talking about, the RAS protein, comes really in a normal state, or we call it wild, or it can be mutated. And we found out that these drugs only work in patients who have wild type or normal tumors. If their tumor mutated, these drugs don't work. So it's really important to know the RAS protein, and this is just a protein in the packet that the epidermal growth factor, really important. About half of people with colon cancer have a mutated cancer, and half have a wild type cancer. So half of patients would be eligible for this based on their RAS status. So it's really important for us to know that, and to know that as quickly as possible, in the early treatment of colon cancer because we have good first-line treatments. The other thing we just learned in the last few years is, in fact, and Dan was talking about, is that the side of the tumor is very important. And looking back at many trials that were done with these agents, found that for people who had left-sided colon cancers, which are about 2/3 of cancers, and left-sided colon cancers, have a general better prognosis, they did much better with these drugs. And people who got these drugs compared to older standard therapies lived for 7 to 10 months longer on average, which is always wants to do, but that's a major advance. So whereas people who had right-sided colon cancers, which is about 1/3, and have a poor prognosis, did not respond to these agents. So we now look at RAS status and side in making those decisions. For a long time, so we had good treatments for patients with normal RAS protein or RAS wild-type tumors, but we didn't have really good treatments for RAS mutated tumors. But although we don't have any randomized trials comparing these new drugs to older standard therapies, there are a couple of new drugs that are targeting a certain subset of mutated RAS tumors that have shown some promise when they're given with either cetuximab or panitumumab, and we hope that larger trials will show that they're a benefit as time goes on. In the pathway that is important for EGFR to work, first protein in that pathway is RAS. After that comes a protein called RAF. And we know now that patients with a very specific mutation called a V600E mutation in that protein do respond well to a new drug called encorafenib and the EGFR monoclonal antibody. And that's become a standard treatment based on randomized trials that have improved survival with these BRAF mutations and the specific BRAF mutations, V600E mutations, who failed first therapy. And right now, across the world, there are trials looking at that in first-line therapy. Fortunately, although this is a very effective therapy, only about 10% of patients with colon cancer have this mutation and have this as an option. So that is frustrating, but we do, for those patients, have this as an option. Dr. Sheffield talked about NTRK, which is a specific protein that can be altered and can stimulate cancer growth. And this only happens in less than 2% of colon cancers. It might even be rarer than that. But we know that in MSI high tumors, the ones that respond, the ones that Dr. Spratlin was talking about, and that respond very well to immunotherapy, there may be as high as 4%. But still, this is a relatively rare tumor. And there's drugs, one called larotrectinib, one called entrectinib, which have shown activity in shrinking tumors and have recently been funded for patients with colon cancer or any type of tumor that has one of these NTRK alterations. And then finally, Dr. Sheffield talked about HER2. This is human epidermal growth factor receptor 2, long known to be important in breast cancer. But recently we know now that about 2 to 6% of patients with colorectal cancer this protein overexpressed and are responsive to some of the drugs that we use to treat breast cancer with this overexpression. And in fact, in patients who has RAS or RAF wild type or the normal types of tumors, it can be as high as 13%. And there are some new drugs called trastuzumab deruxtecan, for example, or traditional trastuzumab, which act on this pathway. Trastuzumab is used very common in breast cancer, which can have activity in patients with colorectal cancer. Again, pretty rare. These are based on small tumors, not on the large randomized trials that some of the other ones are based on. So I think every patient, we want to know their RAS status and their MSI status, because we know we have good treatments that can improve their survival and in some cases their quality of life. NTRK, because we do have some active therapies for that. I think HER2 testing is less common, and somebody who does have a special comprehensive testing and finds out that they have a HER2 overexpressing tumor it's something that they could discuss with their patients. But we don't have large randomized trials about those agents, and they aren't covered by funding in Canada, so they're a little bit harder to obviously. So I think the bottom line is much better understanding the biology of colon cancer in the last 25 years. This is translated into real targeted therapies that exploit these differences in biology, and it's really important for patients to know what type of colon cancer they have, what side it's on, which one of the mutations happens in their colon cancer, so they get discussions with their oncologist about what treatment's best for them.
Yeah. Thank you so much for that. I think you've just demonstrated what I call the power of precision medicine, a terminology that from a patient point of perspective is oftentimes used, but really this whole concept of highly individualized treatment based on who you are and your composition, if I could say it that simply, the advancement that science is bringing to that highly targeted approach to medicine and to treatment is advancing day by day. Would that be a fair statement?
Yeah, that's a very good.
Yeah, right. Dan has can you share your experience around going through what I call the analysis that got you to your treatment? Was there 25 years ago there was one treatment, today the concept of precision medicine is alive and well and growing. How did this fit into your journey? Like, what was the analysis that was done, that you went through, that you experienced to get to your treatment?
Yeah, there was. So initially the pathology that was done from the colonoscopy, as Dr. Berry said, a discussion with my oncologist about those results. And exactly that, I believe I know they tested for the RAS and the RAF, and I think there may have been some other ones in there, but exactly that her recommendation at that time was this drug based on these sulfoxamine, based on these results that I've had, and then we discussed the side effects, possible benefits, possible drawbacks, all those things, and went forward from there.
Yeah, fantastic. Dr. Vuong, I wanted to bridge to you now and to have you talk about this concept of watch and wait, which is what one might perceive to be a little counterintuitive, but if you could explain to us what that means and the benefits of it, that would be terrific.
Okay, so thank you for asking the question. First of all, I just want to clarify, I was the former director of radiation oncology. I think that in radiation oncology for colorectal cancer is now entering a new era of very exciting addition in the treatment of colorectal cancer. In the pelvis, where the rectum is always, and Dr. Richard can also comment on that, been associated with a surgery that have a much more significant impact in terms of function and quality of life of patient at the difference with colon cancer. And as time was going by and imaging and radiation treatment technology has improved thanks to computer science systems, we have been able to treat in a very accurate fashion tumors. And initially, radiation was used in addition to surgery, before surgery, in order to make the surgical resection more curative and more effective. And then we realized that in a certain portion of the patient, there was no tumor found in the surgical specimen, which leads to the question of maybe not all patients need to have surgery as a part of their radical treatment. So this came about 30 years now, almost ago, in Brazil, where Angelita Hakama, who was a colorectal surgeon, when she observed that in many of her patients that was treated with preoperative chemoradiation, there was no tumor, and she decided to initiate a research protocol called watch and wait, where if the tumor disappears, there is no need to operate immediately this patient. And as a result of her observation, there is a significant gain in terms of quality of life for patients. So that's why the program was initiated as watch and wait treatment. And nowadays, thanks to new technology that is now available on the market, we have lots of protocol, either using radiation followed by chemo or chemo radiation with a higher dose, or more recently with the introduction of brachytherapy, which is really based on highly accurate definition of tumor and treatment delivery. We are now offering to patients on protocol the possibility, especially if the tumor will imply a major impact on patient quality of life, like a permanent colostomy, to be observed instead of having immediately to surgery, and surgery will be reserved only if the tumor doesn't disappear or reappear after disappearing otherwise. So this is the area, the new research that we presently are doing, and I think that we think that it's very important for patients to be aware that this is a possible option, and I think this is a very good podium for patients to know that a research protocol that can also be offered to them.
And as Dr. Vuong was saying, I mean, when we're dealing with rectal cancer, specifically low rectal cancer, if a patient can avoid surgery, the quality of life will that patient will have much higher quality of life, because when we have to remove the rectum and reconnect very, very low, it is major impact in terms of bowel function for patients. And so usually I think that as Dr. Vuong was saying, when a patient is dealing with rectal cancer, it's quite important that he or her has the knowledge that there are treatments prior to surgery that should be at least considered in order to try to decrease the chance of having a surgery. Not so much for high rectal cancer, but definitely for low rectal cancer.
I have to imagine that the mental health, the emotional benefits of that treatment approach are tremendous.
It's been a life changer, and there are a few stress related to that watch and wait, because patients need to really come every 3 months. They get a scope, and then they get an MRI every 3 months. So it's the patient has to kind of adhere to quite a few testing, and so. But most patients are, when we talk about going into a protocol, often patients kind of at the beginning are not so enthusiastic. But when we say, well, listen, you have a chance of avoiding surgery, well, that's a really life
thing.
decision. And even now as surgeons, I mean, whenever we see a low rectal cancer, we always say, okay, we got to maximize this treatment in order to maximize the treatment effect, and if we cannot operate, that's, although we're surgeons, I mean, we're well aware of the impact of our act, and if we can avoid surgery, that's definitely a benefit in low rectal cancer.
Thank you. So in certain types of cancer. Yeah,
Right.
right. Yes, thank you so much, Dr. Vuong. And Dr. Richard, I'm going to give the last few moments to you to talk about this concept of a multidisciplinary approach, which is already obvious on this panel based on the conversations that have gone back and forth, but your experiences, the benefits of it, the benefits to patients of the multidisciplinary approach.
We're really in the era of a multidisciplinary approach, and it's been shown 20 years ago in Europe that when you're in a multidisciplinary approach treatment, your outcome is better. And so in our institution, all rectal cancer patients are always presented. All patients with metastatic colon cancer are presented. Now, we've talked a lot about treatment, different treatment modalities, and some patient may only need surgery. So if you have a stage 1 or 2 colon cancer, often the biopsy elements won't change the treatment. So for these patients, often will not necessarily discuss prior to decision making. But for rectal cancer, when you're stage, any stage, you should be presented at a multidisciplinary tumor board. And staged 3-4 cancer of the colon definitely should be done. Initially, these tumor boards at the way beginning, maybe 15 years ago, we had a bit of discussion, and sometimes onco and surgery weren't necessarily in the same pathway. But now in 2022, I mean, everybody's on board, and the patient focus is there. And we've got so many data now that it's complex. It's complex for oncologists to follow our surgery pathways and evolution, and it's difficult for surgeons to follow radiation treatment novelities. And so it's essential that we're together and all of us bring our expertise in order to have a patient like Dan, who, I mean, it has benefited from the different treatments. And here he is 4 years, 3 years down the road and doing super well. And he has multiple types of treatment, and so it's a life changer. And I think that this has to be known by all patients, and whether you're in a smaller setting, hospital, or in a university setting, I mean, you should have access to discussion of your case at a tumor board. And this is really
Dr.
pretty
Richards,
well said.
I don't mean to interrupt you, but I think that's a really critical point, is how is a new patient to a process, a new patient who's entering treatment, how do they know? What do they need to do? How should they ask? Is it really
I think that, as I had told you, some may not need to, but they can easily ask whoever is the first on board when having the diagnosis of a colorectal cancer, is just to ask, okay, I'm here with you, and I've heard about multidisciplinary approach. Now, will my case be discussed? And probably the answer will be yes. And if it's no, well, then why is it not? As I had mentioned, a stage 1 and 2 colon cancer does not necessarily need to be discussed prior to surgery. But I mean, this is, I mean, all of us are very familiar, and we're in university settings, but we're hooked up with local hospitals. Now with the technology, we hook up with kind of provincial hospitals, and often will be for more complex cases, they'll be able to present their case and get kind of optimal treatment.
Mm-hmm. Is there any final comments to add to Dr. Richards on that incredibly important point? Is there any best practices that others are seeing in their centers that they'd like to share?
Maybe
the one. Oh. Sorry, go ahead.
I think that the colorectal cancer organization has a big role in this. It's to provide patient information about what they can expect when they have a diagnosis of colorectal cancer, to have access to a tumor board, as we say, a multidisciplinary opinion. And I think your role is there to provide the option of patient. I think this is what I would say.
Thank you. Yes. Dr. Berry, I think you were going to say something.
I was just going to say that the key thing is understanding that the multidisciplinary assessment is key. I worked in varieties now. One, I worked in a clinic where a radiation oncologist surgeon was right beside me. I'm also work now where in a large region where several hospitals call in, and I think the point about technology really advancing this so that all the patients in our region, which spans 500,000 people across a large geographic area, have access to this tumor board through technology. So the key thing is making sure that your tumor is assessed by a team, it's an experienced team, and that technology has really advanced the ability for the multidisciplinary team to.
Yeah. Thank you so much. I knew that 50 minutes would go quickly, and I think we could probably go for another 50 minutes of exploration, but suffice it to say that we're most grateful for the expertise that you brought to this panel. I mean, the key takeaways really are very much about, science is evolving so quickly that individualized treatments for individuals is becoming more than normal. And that it is, and to, as a patient entering new treatment, understand that a multidisciplinary approach is of benefit to you in certain cases, and to ask the right questions about what's right for you, and to work with the team to get the best for you. Dan, would you like to have any closing words on that?
I agree, absolutely. I think from a patient's perspective, again, having trust in your doctors is huge. I went through a process where it was very difficult, challenging, being diagnosed out of the blue at a young age, but I'm really thankful, especially looking back in the moment, even to with the doctors and the teams, the different surgeons that I had, and specialists that were involved, right down to the counselors at my local hospital as well that were involved. So I think it's true that the whole team aspect of it is so huge. And I think just from a patient's perspective, relying on your support system, whatever that might be, is huge. As well, such as Colorectal Cancer Canada, organizations like that. For me, it's faith, family, and friends really are my three pillars, and that's a huge part for sure.
a beautiful way to close and to bridge into the questions that are coming from the audience at this stage. Thank you so much, everyone.
Thank you.
Great. Welcome back, everyone, for the question session that we now have ahead. I will tell you that as we were speaking, the range and volume of questions that have come in is significant. And so we have this wonderful feature on the platform which actually rates the questions based on the number of people who are interested and liking them. So I'm going to ask them in that order. In many cases, there's not a specific targeted person that is being asked for response. So if you don't mind, I might just direct the question. We'll take it from there. The very first question is, how common is it for removed polyps to go to a pathologist in NED, no evidence of disease patients who are post-treatment? How common is it for removed polyps to go to a pathologist in NED patients who are post-treatment? Dr. Richards, maybe I could ask you.
Yeah, maybe I can answer, and maybe our pathologist will want to add something. So all patients who've been treated for colorectal cancer will have follow-up colonoscopy. And when we find polyps, and up to 30 to 40% of patients will go on to have new polyps, and that's the basic reason for doing the colonoscopy, is to remove these polyps before they become cancers. So when we do remove them, we always send anything that a surgeon takes out needs to go to our friend, the pathologist. So all will be sent to pathology.
Thank you. Dr. Sheffield, did you want to add anything to that?
I agree very much. Everything that's removed from a patient in a hospital setting should come to the pathologist. And in this part of the world, the expectation is that every polyp that's removed during a colonoscopy will get assessed by a pathologist. For the no evidence of disease, that again, it would actually be the pathologist that looks at a rectal excision under the microscope, and it will be after that time that they declare that there's no disease that's not even disease we can find by examination or touching or using a CT scan, but to truly have no evidence of disease, we comb through that with a microscope and make sure there's not even just single tumor cells left behind.
Great. Thank you so much. The next question is, how can I access comprehensive genomic profiling? How can I access comprehensive genomic profiling?
Maybe I could answer that. I think that for starters, it's good to define comprehensive genomic profiling. A lot of tests that you'll get right out of the gate might be a little bit less than comprehensive. And so if they're, for instance, single gene tests for 3 genes in particular, KRAS, NRAS, and BRAF, are very common in many jurisdictions for colorectal cancer. To say that something is comprehensive, it would include multiple classes of mutations, things like amplifications, and we might see that for things like HER2, and also gene fusions, which we might see for emerging targets like NTRK. Comprehensive profiling is not always standard of care, but it is offered in some centers. If you go on Google, you can find that there are a lot of private entities all around the world who are trying to charge for comprehensive profiling, and these are options that are available to you as a patient. Although my recommendation would be to discuss with your oncologist. I think that's really the first step in obtaining comprehensive profiling, and they're there to help guide you and make sure that you make the best decision, because a lot of times you can run into some financial toxicity by trying to do this on your own.
Thank you very much.
Maybe I can just add to that as well. You know, as a medical oncologist, we look for certain things and we're able to direct our treatment based on certain findings. But sometimes these, in quotation marks, comprehensive testing studies do reveal other other changes that really have no bearing, and it can cause a lot of anxiety. A lot of it is just not needed, and just raises extra questions. So I would really, really encourage patients to talk to their physicians about what is actually needed, and be cautious about spending money where it might not be required.
Yeah, thank you for reinforcing that. I had a personal experience with a family member who we in fact did Google that, and what comes up is overwhelmingly. So all roads need to lead back to the physician. Thank you for reinforcing that. A question from Tammy.
I think
please
can I just
go
add
ahead.
one thing to that, and I agree
Of
with
course.
I agree with what's been said, and I think the question I would ask is, how do we use the information from that, right? I think, if we did that type of testing, how would we use that information? I think that it is good to know that across the country there are various research protocols that include extensive comprehensive genomic profiling that's linked to access to clinical trials for agents that might be linked to a result. So I think that, as Dr. Spratlin said, discussing with your oncologist is a critical part of this.
It's incredible how 50 minutes went quickly. A 10-minute Q&A goes even more quickly, I might add, with a list of very lengthy questions, which I wanted to suggest that when I ask one more question of the panel, and please know that the questions that don't get asked today will be shared with everybody, and colorectal cancer and an amazing team there will be reaching out to those of you to ensure that your questions do get answered. So the last one here is, I only had MSI assessed, but nothing else, with a negative result. I've asked for KRAS and others with no success. What determines which patients are assessed for other biomarkers?
So I can take a stab at that. In some jurisdictions like Ontario now, there's reflex testing for certain patients for MSI. So it's actually much more common now for patients to have MSI tested for their tumor. In terms of other genomic profiling like KRAS, for instance, it depends a lot on the stage of your tumor and what line of treatment you're accessing. So for instance, if you did not have a tumor that had metastasized or become stage 4, KRAS would not be a valuable piece of information in guiding your therapy. So I think it gets back to the point we made just previously, is discussing with your oncologist what's appropriate for you, why the results are available that are available, and for something like KRAS, why that may or may not be helpful in your particular case.
Great. Any other things to add to that final comment? If not, I'm going to close the session by thanking Dr. Spratlin, Dr. Sheffield, Dr. Barry, Dr. Vuong, Dr. Richard, and of course our patient Dan. Thank you all so much for participating today.